Hi, my name is Laura, and welcome to my audio version of the Family Medicine, Urology, and Renal EOR Study Guide. The rest of the family medicine topics can be found on my channel, but I'll link them below as well. This review is going to follow the PAEA, Urology and Renal portion of the Family Medicine End of Rotation Exam topic list, and I'll timestamp all the topics below in case you'd like to skip around. Let's start off with the biggest topic first. Glomerulonephritis. This is an inflammation of the glomeruli, the network of capillaries that filters blood. It presents with hypertension, azotemia or high BUN, hematuria, proteinuria, and red blood cell casts in the urine. Glomerulonephritis occurs when immune cells damage the podocytes that line the glomerulus. Podocytes normally have small gaps between them and a negative charge to prevent large molecules from getting through. But when the podocytes are damaged, we start to see proteinuria and hematuria because larger molecules are now able to leak through. Think of glomerulonephritis as a leaky glomerulus. This leaking changes the pressure difference that drives filtration, so GFR is reduced. Glomerulonephritis can either be acute or chronic, and the etiologies of glomerulonephritis can be classified as either nephritic or nephrotic syndrome, based on their clinical presentation. Most, but not all, etiologies of nephrotic syndrome tend to be chronic, which is why when we talk about acute glomerulonephritis and AKI, we usually talk about nephritic syndrome. Nephritic syndrome presents with gross hematuria, causing urine to look dark. This is a hallmark symptom. It also presents with proteinuria, hypertension, peripheral edema, oliguria, fever, abdominal or flank pain, and malaise. Urinalysis shows gross hematuria with red blood cell casts, proteinuria, and a high specific gravity. There will be varying degrees of increased BUN and creatinine, and gold standard diagnosis is a renal biopsy, but it's not always done. There are 5 big etiologies of nephritic glomerulonephritis to know: IgA nephropathy, post-infectious, membranoproliferative, Goodpasture's disease, and vasculitis. Let's start with IgA nephropathy, also called Berger's disease. It's the most common cause of acute glomerulonephritis worldwide and typically occurs a few days after an upper respiratory or GI infection as a result of overproduction of IgA immune complexes. Diagnosis is with positive IgA mesangial deposits on immunostaining. Treatment is ACE inhibitors and corticosteroids. The next nephritic etiology is post-infectious glomerulonephritis, commonly post-streptococcal glomerulonephritis, a couple weeks after some sort of group A strep infection, so pharyngitis, impetigo, etc. Diagnosis is made by high anti-streptolysin titers and low serum complement. Treatment is supportive, and antibiotics are an option. Next is membranoproliferative glomerulonephritis. It's caused by lupus or viral hepatitis, and this one is unique because it usually presents with a mixed nephritic and nephrotic presentation. The last 2 nephritic etiologies are Goodpasture's disease and vasculitis, which are both rapidly proliferative glomerulonephritises. They are associated with poor prognosis and rapid progression to end-stage renal failure within weeks to months. Goodpasture's disease is a type 2 hypersensitivity reaction. Basically, the body makes IgG antibodies against the collagen of the alveoli and glomerular basement membrane, so patients present with hemoptysis and glomerulonephritis. Diagnosis is made by biopsy, which shows linear IgG deposit in the glomeruli or alveoli. Treatment is high-dose corticosteroids plus cyclophosphamide, and plasmapheresis can be used to remove the antibodies. The other rapidly proliferative glomerulonephritis is vasculitis, which is just an inflammation of blood vessels. There are 2 main vasculitis conditions that cause glomerulonephritis: granulomatosis with polyangiitis, and microscopic polyangiitis. Granulomatosis with polyangiitis, which is also called Wegener's, is a small vessel vasculitis with granulomatous inflammation and necrosis of the nose, lungs, and kidneys. It presents with a triad of upper and lower respiratory tract symptoms and glomerulonephritis. Symptoms can include fever, nasal congestion, saddle nose deformity with cartilage involvement, epistaxis, otitis media, sinusitis, hemoptysis, dyspnea, hematuria, and proteinuria. Diagnosis is made by presence of C-ANCA antibodies. The other vasculitis, microscopic polyangiitis, is also a small vessel vasculitis, but there is no necrotic or granulomatous inflammation. It presents with fever, malaise, a palpable purpuric rash, glomerulonephritis, and lung symptoms like hemoptysis and dyspnea. And it's diagnosed by presence of P-ANCA antibodies. Both vasculitis conditions are treated with corticosteroids plus cyclophosphamide. So just a quick recap. Nephritic syndrome etiologies include IgA nephropathy, post-infectious, normally strep, membranoproliferative, and the rapidly progressive glomerulonephritises, which are Goodpasture's disease and vasculitis. Most of these are self-limited with a decent prognosis, except for the rapidly progressive glomerulonephritises. And besides the treatments that we already mentioned, consider loop diuretics for edema and beta blockers or calcium channel blockers for the hypertension. Okay, now let's move on to nephrotic syndrome. Nephrotic glomerulonephritis presents with heavy proteinuria, hypoalbuminemia, edema, and hyperlipidemia. Patients present with pitting peripheral edema and periorbital edema, especially in children, as a result of the hypoalbuminemia, which decreases oncotic pressure. The gold standard for diagnosis is a 24-hour urine collection, which shows proteinuria more than 3.5 grams per day in nephrotic syndrome. Urinalysis will also show oval fat bodies that are Maltese cross-shaped. And a renal biopsy can differentiate the nephrotic etiologies, but it's not always needed. There are 3 primary etiologies to know for nephrotic syndrome: minimal change disease, focal segmental glomerulosclerosis, and membranous nephropathy. Minimal change disease accounts for the majority of nephrotic syndrome in children. The pathogenesis of this disease is unknown, and it's considered idiopathic. If a child presents with nephrotic syndrome and improves with corticosteroids, then minimal change disease can be assumed. The treatment of choice is prednisone. The next nephrotic etiology is focal segmental glomerulosclerosis. It can be idiopathic or associated with HIV, IV heroin use, hypertension, or reflux nephropathy. It's characterized by sclerosis or fibrosis within the glomerulus, and it's treated with corticosteroids. The last nephrotic etiology is membranous nephropathy, which is characterized by a thickened glomerular basement membrane caused by immune complex deposition. It can be idiopathic or associated with lupus, viral hepatitis, malaria, and certain drugs. And it usually presents with a mixed nephritic and nephrotic presentation. So those are the 3 primary etiologies of nephrotic syndrome: minimal change disease, focal segmental glomerulosclerosis, and membranous nephropathy. There are also secondary causes, the most common of which is diabetes. The other secondary causes include lupus, amyloidosis, hepatitis, Sjogren's syndrome, sarcoidosis, preeclampsia, malignancy, infection, and certain medications. In general, treatment of nephrotic syndrome is corticosteroids when indicated, diuretics for the edema, ACE inhibitors for the proteinuria, and lifestyle modifications for the hyperlipidemia and to offset the urine protein loss. And that wraps up glomerulonephritis. The next topic is BPH, benign prostatic hypertrophy. This is prostate hyperplasia, particularly of the transitional zone, that causes bladder outlet obstruction. It's incredibly common in elderly men because the prostate gradually enlarges with age and increase in dihydrotestosterone production. This leads to urinary symptoms like frequency, urgency, nocturia, hesitancy, weak stream, or incomplete emptying. BPH can be diagnosed with a digital rectal exam, or DRE, which will feel like a uniformly enlarged, firm, rubbery prostate. Prostate-specific antigen, or PSA, is often ordered as well, and an increase in PSA is correlated with symptom progression. Other tests that might be done include a urinalysis to rule out UTI, and cystoscopy if there's a risk of bladder cancer. Treatment of mild BPH symptoms is simply observation. It's also recommended to avoid anticholinergics and antihistamines, which can cause urinary retention. Treatment of moderate or severe BPH can include medications or surgery. 5-alpha reductase inhibitors, like finasteride or dutasteride, are one pharmacological option. Remember, the prostate enlarges with increased dihydrotestosterone, or DTH, production. Well, testosterone is converted into DTH by 5-alpha reductase. So, 5-alpha reductase inhibitors stop this conversion and suppress prostate growth. They don't necessarily provide symptom relief, but they do improve the clinical course. Side effects include sexual dysfunction. Another medication option is alpha-1 blockers, the most uroselective of which is tamsulosin, but others include alphazosin, doxazosin, and terazosin, the Zosins. They have no effect on clinical course, but they do provide quick symptom relief by inhibiting alpha-1 receptors, causing smooth muscle relaxation of the prostate and bladder and decreased urethral resistance. This results in increased urinary outflow. Side effects include orthostatic hypotension. In severe cases that are refractory to medications, surgical intervention might include a transurethral resection of the prostate, also called a TURP, T-U-R-P. This surgery removes excess prostate tissue to open up the obstruction. Side effects of this procedure can include sexual dysfunction and urinary incontinence. Another prostate condition is prostatitis, which is an acute or chronic prostate inflammation secondary to an infection. Acute prostatitis presents with fever, chills, malaise, low back pain, and urinary symptoms like frequency, urgency, dysuria, hesitancy, poor stream, or incomplete emptying. In males over the age of 35, causative organisms are typically gram-negative, especially E. coli. In males under the age of 35, chlamydia and gonorrhea are the most common organisms. On a digital rectal exam, the prostate will be very tender, possibly hot, and boggy. Boggy is a buzzword for prostatitis. Diagnosis is made by urinalysis with culture, which will be positive in acute prostatitis, but often negative in chronic prostatitis. Treatment is based on the causative organism. So for patients older than 35, treatment is fluoroquinolones or Bactrim. And in patients younger than 35, we treat for chlamydia and gonorrhea with ceftriaxone plus doxycycline. Now, chronic prostatitis. This one is more variable since it can be asymptomatic or have symptoms similar to acute prostatitis, and it often presents as recurrent UTIs. The most common causative organism in chronic prostatitis is E. coli. On a DRE, the prostate is usually not tender, but still boggy. Remember, that's the prostatitis buzzword. Urinalysis and culture are often negative, but sometimes a prostatic massage is done to increase bacterial yield on a urinalysis. but never do this on an acute prostate. Treatment is fluoroquinolones and Bactrim. And in refractory chronic cases, a TURP can be considered. The next topic is epididymitis. This is inflammation of the epididymis, and it's usually caused by a bacterial infection, acquired by retrograde spread through the vas deferens. In younger men, younger than 35, the most common pathogens are chlamydia and gonorrhea. In men older than 35, the most common pathogens are E. coli, Pseudomonas, and Klebsiella. Patients usually present with gradual onset of unilateral scrotal pain, erythema, and swelling. Other symptoms might include dysuria, fever, chills, groin, or abdominal pain. There will be a positive PREN sign, which is relief of pain with elevation of the scrotum. They'll also have a normal cremasteric reflex. Scrotal ultrasound will show enlarged epididymis with increased testicular blood flow. Urinalysis will show white blood cells, pyuria and/or bacteriuria, and make sure to get a urine culture and STD testing. Treatment is symptomatic management with scrotal elevation and NSAIDs, and also treat the underlying bacterial infection. Chlamydia and gonorrhea get doxycycline and ceftriaxone, and then enteric organisms get fluoroquinolones like levofloxacin. And children can be given cefalexin or amoxicillin. The next topic is orchitis, which is inflammation of the testicles, and it's usually caused by a viral infection, but can also be bacterial. It's caused by ascending infection from the urinary tract. The most common pathogens are mumps, Coxsackie, rubella, echovirus, and parvovirus. Presentation is similar to epididymitis. In fact, orchitis is normally seen with epididymitis, except in the case of mumps, where orchitis can present alone. So patients present with gradual onset of unilateral scrotal pain, erythema, and swelling. Other symptoms might include dysuria, fever, chills, groin, or abdominal pain. There will be a positive PREN sign, which is relief of pain with elevation of the scrotum. They will also have normal cremasteric reflex. Scrotal ultrasound will typically show an enlarged epididymis with increased testicular blood flow. Urinalysis will show white blood cells, pyuria and/or bacteriuria. Treatment is symptomatic management with scrotal elevation and NSAIDs. If the underlying cause is bacterial, then antibiotics can be given. The next topic is balanitis, which is inflammation of the foreskin and head of the penis. It occurs most often in uncircumcised individuals and can be caused by infection, poor hygiene, and uncontrolled diabetes. Symptoms include pain, redness, and discharge under the foreskin. Treatment depends on the cause. Often antifungals or antibiotics are prescribed. In extreme cases, the foreskin might need to be removed via circumcision. The next topic is testicular cancer, which is curable with treatment and has a good prognosis. The most common risk factor is cryptorchidism, which is associated with a 40-fold increased risk. Klinefelter syndrome is another risk factor. Testicular cancer can be divided into germinal cell tumors, which make up the grand majority, and non-germinal cell tumors. Germ cell tumors are typically malignant and can be further divided into seminomas and non-seminomas. Seminomas can be remembered with the 4 S's. Simple, meaning they lack tumor markers. Sensitive to radiation. Slow growing, and associated with stepwise spread. Non-seminomatous germ cell tumors include embryonal cell carcinoma, teratoma, yolk sac tumors, choriocarcinoma, and mixed tumors consisting of seminomatous and non-seminomatous parts, but treated like non-seminomas. Okay, so those were the germ cell tumors. The non-germ cell tumors include Leydig cell tumors, Sertoli cell tumors, gonadoblastomas, and testicular lymphoma. Of note, Leydig cell tumors can secrete hormones that can cause precocious puberty in kids and reduced libido or gynecomastia in adults. Sertoli cell tumors can secrete hormones as well. The textbook description of testicular cancer is a firm, painless testicular mass that cannot be separated from the testicle. It might have a feeling of heaviness in the scrotum, and a hydrocele will be present in about 10% of patients. Gynecomastia might be present in about 10% of patients as well, particularly with hormone-secreting tumors. Diagnosis is made by scrotal ultrasound, and labs, particularly increases in alpha-fetoprotein, beta-HCG, and LDH, can indicate testicular tumors too, specifically non-seminomas. Treatment of low-grade non-seminoma, meaning it's limited to the testes, is orchiectomy with retroperitoneal lymph node dissection. Treatment of low-grade seminoma is orchiectomy, followed by radiation. And treatment of high-grade seminoma is chemotherapy, followed by orchiectomy and radiation. The next few topics have to do with infections of the urinary tract, starting from the lower urinary tract. So, urethritis is inflammation of the urethra secondary to infection. Symptoms can include pain, itching, burning, urinary frequency, and urethral discharge. The most common causes of urethritis are gonorrhea and chlamydia. Diagnosis is made by first catch or first void urine collection and doing a urinalysis, culture, and nucleic acid amplification test on that urine sample. Positive leukocyte esterase is suggestive of urethritis, and the nucleic acid amplification test is the most sensitive and specific test for gonorrhea and chlamydia. Complications to know for urethritis vary between males and females. In males, complications include epididymitis, prostatitis, infertility, reactive arthritis, and septic arthritis. In females, complications include pelvic inflammatory disease, infertility, ectopic pregnancy, premature delivery, and septic arthritis. In order to prevent these complications, treatment is important. For gonococcal urethritis, 1 dose of ceftriaxone IM is given. For non-gonococcal urethritis, most commonly chlamydia, azithromycin or doxycycline is given. However, over a quarter of these patients have a co-infection, so treating both gonorrhea and chlamydia presumptively is recommended, pending the test results. While we're on the topic of STIs, let's go over these infections. Chlamydia is the most common bacterial STI in the US. It's caused by the gram-negative bacteria Chlamydia trachomatis. This infection can be asymptomatic, especially in men, but can also present with watery or mucopurulent discharge, pruritus, dysuria, dyspareunia, or abdominal pain. In females, chlamydia can cause pelvic inflammatory disease and lead to infertility and ectopic pregnancy. It can also cause reactive arthritis in individuals who are positive for the HLA-B27 gene. And reactive arthritis can be remembered by the saying, can't pee, can't see, can't climb a tree, because it causes urethritis, conjunctivitis, and arthritis. Gold standard diagnosis of chlamydia is a nucleic acid amplification test of the discharge or the urine, and treatment is either doxycycline or azithromycin. There are high rates of co-infection with gonorrhea, so these patients should be tested for that infection too. And sexual partners need to be treated as well to avoid passing the infection back and forth between them. Gonorrhea is another common bacterial STI. It's caused by the gram-negative diplococci Neisseria gonorrhea. Symptoms are similar to chlamydia, as it can be asymptomatic, but it can also present with mucopurulent discharge, cervicitis and urethritis, dysuria, and urinary frequency. In females, gonorrhea can cause pelvic inflammatory disease and lead to infertility and ectopic pregnancy. It can also cause reactive arthritis or septic arthritis. Gold standard diagnosis is a nucleic acid amplification test, and first-line treatment is ceftriaxone as a one-time intramuscular injection. Because rates of co-infection with chlamydia are so high, patients with gonorrhea need to be tested or treated for chlamydia as well, and their sexual partners need to be treated to avoid passing the infection back and forth. The next topic is cystitis, which is inflammation of the bladder, often secondary to infection. E. coli is by far the most common culprit, but other pathogens include Proteus, Enterobacter, Klebsiella, Pseudomonas, Staph saprophyticus, especially in sexually active women, and Enterococci, especially with urinary catheters. Risk factors in women include sexual intercourse, hence the phrase honeymoon cystitis, pregnancy, since hormones cause ureter dilation, and post-menopause due to decreased bladder tone and alteration of normal vaginal flora with decreased estrogen. Men, on the other hand, rarely get UTIs and should get a workup if they present with one. Symptoms of cystitis include dysuria, burning with urination, urinary frequency, urgency, hematuria, or suprapubic discomfort. Diagnosis is made by urinalysis, which will show bacteriuria, positive leukocyte esterase, and likely positive nitrites. What does this mean? The majority of bacteria that cause UTIs produce nitrate reductase, which transforms urine nitrate into nitrite. Positive nitrites can indicate infection with one of these bacteria, but negative nitrites does not necessarily rule out UTI. On the other hand, positive leukocyte esterase corresponds to pyuria, which is essentially pus in the urine, and almost always presents with UTI. Hematuria is another common finding too. Now, the gold standard diagnosis is a urine culture, which takes a few days, but results will identify which bacteria is causing the infection. This is helpful in the case of complicated cystitis, but often unnecessary in uncomplicated cases. Treatment of cystitis is by antibiotics. Treatment options in uncomplicated cystitis include nitrofurantoin, Bactrim, and fluoroquinolones like ciprofloxacin. Complicated cystitis, meaning patients with symptoms for longer than a week, pregnancy, diabetes, immunosuppression, urinary catheter, the elderly, or males, these all get a fluoroquinolone, ceftriaxone, or an aminoglycoside. The exception is pregnancy, which is treated with amoxicillin, augmentin, cefalexin, cefpodoxime, or fosfomycin, and nitrofurantoin can be used after the first trimester. The next topic is pyelonephritis, which is inflammation of the kidney, specifically the renal pelvis, which is the structure that drains urine into the ureter. This most often occurs as a result of an ascending infection from the lower urinary tract, meaning the bladder and urethra, to the upper urinary tract, the ureters and kidneys. So pyelonephritis, as an upper UTI, shares a lot of the same risk factors and pathogens as urethritis and cystitis, or the lower UTIs. So the most common etiology is, again, E. coli. Symptoms overlap as well, but pyelonephritis can also include fever, tachycardia, back or flank pain, nausea, vomiting, and positive CVA tenderness. Diagnosis is made by urinalysis, which shows pyuria, bacteriuria, and notably, white blood cell casts. If there are white blood cell casts in the UA, then it's pyelonephritis. Treatment of pyelonephritis is a fluoroquinolone like Cipro or levofloxacin, ceftriaxone, or an aminoglycoside. Next is nephrolithiasis, or kidney stones. These are more common in men and most commonly associated with reduced fluid intake. There are 4 types of kidney stones: calcium oxalate and phosphate stones, uric acid stones, struvite stones, and cystine stones. The calcium oxalate ones are by far the most common and associated with increased protein and salt intake, which inhibits calcium resorption. Uric acid stones are associated with foods high in purine. Struvite stones are also called magnesium ammonium phosphate stones and might form staghorn calculi. They're also associated with chronic UTIs. Lastly, cystine stones are the result of a genetic disorder. Kidney stone patients present with sudden colicky flank pain all over the costovertebral angle that often radiates to the groin, nausea and vomiting, and they don't tend to sit still since it's hard for them to find a comfortable position. They'll have positive costovertebral tenderness on exam, or CVA tenderness, possible hematuria, and urinary frequency or urgency. Diagnosis is made by a CT abdomen and pelvis without contrast. If CT is contraindicated, ultrasound is used. A KUB X-ray, which stands for kidneys, ureters, bladder, KUB X-ray will only show some stones, the calcium and struvite stones. And the actual gold standard test is an intravenous pyelogram, but this is not commonly ordered. A urinalysis is often ordered alongside the imaging, and it might show hematuria. Patients are also given a strainer to urinate through at home to catch the stone for analysis later on. Stones that are less than 5 millimeters in diameter have an 80% chance of passing spontaneously. These stones are treated with IV fluid hydration, analgesia like morphine and ketorolac or Toradol, antiemetics, and alpha blocker therapy with tamsulosin to facilitate the passage. Stones greater than 7 millimeters in diameter have a 20% chance of passing spontaneously, so these stones are treated more aggressively. Options include extracorporeal shockwave lithotripsy to break up large stones, uretoscopy with stent for relief of an obstructed kidney, and percutaneous nephrolithotomy to open up and remove the stones in patients that fail more conservative measures. The last topic is hernias, specifically direct and indirect inguinal hernias. A hernia is essentially a hole through which insides can protrude. In the case of inguinal hernias, it's the contents of the abdominal cavity that might protrude through the hernia into the inguinal canal. Inguinal hernias are classified into direct and indirect based on their relation to the inferior epigastric blood vessels. Indirect inguinal hernias are much more common than direct. In indirect hernias, the hernia sac passes through the internal inguinal ring down the inguinal canal, sometimes passing into the scrotum or labia. So the origin of the sac is lateral to the inferior epigastric artery. These can also be congenital, presenting in infants, and while they are more common in men, they are the most common type of hernia overall for both men and women. Remember, indirect goes through the internal inguinal ring. Now, for direct inguinal hernias, the hernia sac is medial to the inferior epigastric artery, protruding through Hesselbach's triangle. This anatomic landmark, also called the inguinal triangle, is defined by the borders of the rectus abdominis, the inferior epigastric vessels, and the inguinal ligament. And direct inguinal hernias do not reach the scrotum. Hernia symptoms vary widely. They can be asymptomatic, present with swelling at the hernia site, enlarge with increased intra-abdominal pressure, and indirect hernias might present with scrotal swelling. They can also become incarcerated, in which it becomes painful and the contents are not able to be reduced back through the hernia. And worse yet, they can become strangulated, where the hernia contents become ischemic, compromising blood supply. This is a surgical emergency. In fact, management of symptomatic inguinal hernias is typically surgical, and they can be repaired in an open fashion, laparoscopically, or robotically. And with that, we wrap up the urology and renal portion of the Family Medicine EOR exam study guide. If you're listening to these videos in order, the next section is hematology, which I'll link below once it's up. If you're listening as these videos roll out, there's a whole lot of EOR content to come, so stay tuned, subscribe to the channel, and thank you so much for listening. Happy studying, and I'll see you in the next video.